more in history and whatnot, and younger patients, we should check germline BRCA. Monarch E, hormone positive, large residual disease. We used to treat and ovarian suppression. Now they were randomized to receive abemaciclib, which is CDK4/6 inhibitor, and that also improves the distant disease-free survival and invasive disease-free survival. Modest, so high-risk patients, we treat them with that. And the approval, by the way, is for patients with Ki-67 more than 20%. And then finally, the Create X, residual disease, triple negative. They were randomized to receive, after surgery, to receive 6 months of capecitabine, which is chemotherapy, oral chemotherapy, versus standard of care. And that also showed improvement in overall survival. Most of these patients, the benefit was for triple negative, okay? So for triple negative patients, residual disease, now we have so many options. What if you have olaparib, if you have germline mutation and you have residual disease? Which one do you give, olaparib or Create X? Do you continue with pembrolizumab? So this is really what's called data-free zone, right? And we, from physicians to physicians, depends on how aggressive or non-aggressive you are. So this is the conclusion. So neoadjuvant treatment is standard of care in triple negative and HER2 positive. If you don't do that, you are harming patients, in my opinion. In most of the cases, not in very small tumors. Adaptive therapy, you should pay attention to the adaptive therapy based after neoadjuvant treatment. BRCA testing is important to adopt the Olympia trial in the adjuvant setting. Sequencing the treatment, as we just said, is an issue now. We really don't know what to do for patients who have residual disease and have many options. Do we sequence them? Do we give them all at once? And then finally, the neoadjuvant hormonal therapy is an option for some patients. Thank you very much.
We move to the we move to next speech. Because of interest time, we keep all the discussion after that. Dr. Zainab Al Musa, she will talk about febrile neutropenia. She's a consultant pediatric infectious disease and chief of academic affairs, deputy chief officer, chief of staff. So basically, she's going to talk about very common post-chemotherapy in our patients. After her speech, we'll have a discussion.
Assalamu alaikum. Good afternoon, everyone. My presentation will be lighter than the previous ones. I consider myself as an outsider between the highly distinguished oncologists. So I'm an ID physician, a pediatrician in origin, and subspecialize in infectious diseases. So my outline of the outlines will be around the definitions of neutropenia, febrile neutropenia, the classification, risk stratification, the diagnostic approach, and then the management. Then basic to the basic sign, what is neutrophils or polymorph neutrophils? It develops from the blood marrow. It's involved in the acute inflammation and host defense. There is daily production of neutrophils, so the bone marrow is very active in producing the neutrophil with a rate of 1 to 1.5 thousand per kg. Only 2 to 5% of these neutrophils enter the blood circulation. The lifespan varies hours up to 10 days. And the neutrophils and the band represent 50% of the whole granulocyte, or the WBCs. So if you can see this diagram, maybe our colleagues in the lab can know more. Beginning from the hemocytoblast, then the common myeloid progenitor, down to the myeloblast, then we can have the neutrophils, the mature neutrophils. Because I'm a pediatrician, we always go to the normal values based on the age. So each normal value of WBCs and ANCs. And we can calculate the ANC, which is the absolute neutrophil count, by this simple formula. There are main causes of neutropenia, four main causes, which is decreased ineffective production or increased margination. We can classify the severity of neutropenia based on the number. So mild is 1,000 to 1,500, moderate 500 to 1,000, severe less than 500, and profound is less than 100. We can classify neutropenia in general. I'm talking about neutropenia in general. I know that the oncologists want to go to directly to the neutropenia and cancer and hematopoietic stem cell, but I can see some residents here who want to seek some basic knowledge. So neutropenia can be classified to acute or transient, and chronic, which is the persistent one. Acute can be caused by infection, whether it's viral, bacterial, or even fungal. Drugs like anti-epileptic or chemotherapy. Immune, like autoimmune or isoimmune neutropenia. The chronic one can be classified again to intrinsic or extrinsic. This table classifies the chronic neutropenia. So extrinsic is due to nutritional or drug or immune, and the intrinsic is due to immunodeficiency, neutropenic syndrome. Our immunologists, they can count all the syndromes like Shidiak-Hagashi, Griselli, Hermansky-Bodlak, and the others. And this is a nice diagram to classify neutropenia in another way, like if it's congenital or acquired. So you can see just by asking history, the patient has neutropenia before or no. If no, so this is most likely acquired because of leukemia, drugs, viral infection, and etc. But if the patient had previously neutropenia, so this is most likely congenital. Then you go to the phenotype. If the patient has abnormal phenotype, you go to those syndromes. If not, you will go to the congenital neutropenia like Costman, cyclic neutropenia, chronic benign neutropenia, which is the most common in frequency. To the core of this presentation, we will talk now about the fever in a patient with cancer or hematopoietic stem cell transplants. There are multiple guidelines. We know that we usually rely on guidelines on treating febrile neutropenia. Some of our dear hematology oncologists like to treat just by the gut feeling or just because they're afraid of their patients. So since 1996, we have a solid guideline from the IDSA. Then at 2002, then updated at 2010, and I consider that 2010 is the most solid guidelines for febrile neutropenia. It was and American Society of Clinical Oncology. Then at 2017 was a minor update. Then lastly, we have an update in 2019. So this is the definition of febrile neutropenia for our colleagues, residents. More than 38.3 or 2, consecutive reading of more than 38 for 2 hours, and an ANC of less than 500 or expected to fall below 500. Some stats about febrile neutropenia. Every 1,000 patients is receiving chemotherapy is expected, 8 of them is expected to have febrile neutropenia. 25 to 30% of them will have major complication. We mean by that renal failure, heart failure. 10% are expected to have mortality. So this is a serious disease. The mean cost of hospitalization for each febrile neutropenia is around 50,000 Saudi riyal. And now we're going into value-based healthcare. We have to calculate the cost. So we really need to treat and maybe prevent febrile neutropenia. There are some differences between solid tumor and hematological malignancies in the incidence rate of febrile neutropenia. So in cases of solid tumor, the febrile neutropenia is mainly low risk. The febrile neutropenia is expected to be less than 7 days. And in hematological malignancies and hematopoietic stem cell, especially in the conditioning phase, it will last up to 14 days, and the incidence rate is much higher. We have to pay attention that the fever in cases of neutropenic patient, it might be the only sign of infection because of the lack of ability to mount inflammation signs. So we have to be really careful. There are multiple evidence proved that the duration and the severity of neutropenia correlates in a positive way with the risk of infection. So the risk of infection will increase with the severity and duration of neutropenia. How to classify whether it's high risk or low risk based on multiple tools. We have this, the MASC prognostic index. It has a scoring, symptoms, hypertension, obstructive pulmonary disease, age, and at the end you will do the scoring. If it's more than 21, this is a low risk disease. And if it's below 15, this is high risk disease. The MASC score also enable you to decide if the patient can go to outpatient therapy or IV therapy. I know that most of our dear oncologists, they don't prefer outpatient therapy for febrile neutropenia, but it's a real option here. This is another tool, which is the Talcott's rule. It also helps in characterizing the high risk or low risk. So group 4 is low risk. The last score is the CISNI tool. It has also another scoring criteria, and I'll show you how to use it. For example, we don't depend on the MASC score for the classification. We can use the 3 scores together. This is published in 2018 by the ASCO and the IDSA, how to use the MASC score and the other 2 scores in classifying your low risk or high risk patient, and to decide whether to go for outpatient or inpatient. This is published online and we can always go back to it. So in general, just in a simple word, who is at low risk? The low risk is MASC score more than 21, or neutropenia expected to resolve within 7 days, and no active medical comorbidity, as well as stable and adequate hepatic function and renal function. So no comorbidity, no hepatic renal affection, and neutropenia will be resolved by less than 7 days. This is the low risk patients. The high risk is almost the opposite. So there is profound neutropenia, and we defined it by less than 100 ANC, and to exceed more than 7 days. And presence of any of those comorbidities like hemodynamic instability, oral or GI mucositis, GI symptoms, neurological conditions, pulmonary infiltrate, intravascular catheter tunnel infection, and evidence of hepatic and renal insufficiency. The diagnostic approach for cases of febrile neutropenia, we have always to start with history. So just take a history about the nature of chemotherapy given, what type of chemotherapy, was it intensive chemotherapy or not, any prophylactic antibiotic was given, because we know if the patient is taking prophylactic fluoroquinolone, he is at risk of multi-drug resistant organism, and maybe he is not entitled for outpatient therapy. Concomitant steroid use, surgical procedures, allergy to tailor your antibiotic, and your positive past antibiogram. You have to check your patient in specific sites, specifically in the CNS, respiratory indwelling catheters, you have to check the catheters very well, the perineum and the genitals, skin and soft tissue, looking for rashes, petechiae, sign of infection, oropharyngeal and GI examination. For any case of febrile neutropenia, we have to take our investigation. We don't have to delay antibiotic to wait for the investigations. But we always have to take 2 sets of blood culture. We mean by set is 2 type of culture, aerobic and anaerobic. Of course, for adults, we can take up to 20 ml. For pediatric, we use less amount of blood, like 3 to 5, maybe 7 ml. Also 2 sets. We have to take it from the central line as well as peripheral line. There were a debate about taking peripheral line culture, but now it's proven that we have to take it from both central and peripheral. We have to take urine analysis and urine culture. We don't have to take it by catheter. We have to have it midstream or clean catch. Of course, inflammatory markers like CRP, procalcitonin is meant for follow-up mainly. We have to take chest X-ray, especially the ones who have respiratory symptoms. There are additional investigations that are not routinely considered at the beginning, but you might consider it. For example, CT chest or MRI, abdominal radiograph if the patient has abdominal symptoms, stool analysis if the patient has diarrhea or prolonged hospitalization before, a lumbar puncture if there is suspicion of meningitis. And we know that by evidence, serum galactomannan and fungal serology is not routinely recommended. The most common organism we know is gram-negative, especially the Enterobacteriaceae. E. coli, Klebsiella, Pseudomonas is at risk. In the past 5 years, we have more and more of gram-positive, like coagulase negative, strep, MRSA, and also VRE. As I said, the use of fluoroquinolone widely as prophylaxis has increased the risk of MDR organisms. Between pediatric and adult, the standard of therapy before for chemoprophylaxis or antibiotic was called moxazole. Now, the studies and the evidence is stronger towards the fluoroquinolone, whether it's levofloxacin, moxifloxacin. But there is a strong debate in the evidence about whether to encourage or discourage the use of chemoprophylaxis because of the risk of the emerging resisting strains. I know that our oncologists are towards giving the chemoprophylaxis. This is reassuring for our dear oncologists that the most recent update of Cochrane meta-analysis still recommend the use of ciprofloxacin as chemoprophylaxis, especially for intensive chemotherapy. This is your area. GCSF is recommended if you are expecting prolonged neutropenia or the risk of neutropenia will be more than 20%. So GCSF is recommended. This is the adults' recommendation if there is serious comorbidity or the age more than 60 or the risk of neutropenia more than 20%. The most important for GCSF is that you have to reassess at every cycle the indication of GCSF. I think this is the most important slide for following during your management. This is empiric at day 1 or day 0 as we call it. To classify low risk or high risk, if the patient is high risk, we have to go with IV antibiotic, and we will discuss the IV antibiotic later on, and the indication of vancomycin. If the patient is low risk, we can go with oral antibiotic, and oral antibiotic we use usually fluoroquinolone and amoxiclav if the patient is not allergic. If he's allergic, we can use clindamycin instead of amoxiclav. I know this slide will be somehow irritating for our oncologists. Monotherapy versus combination therapy for cases of febrile neutropenia. We mean by monotherapy like anti-pseudomonal penicillin, anti-pseudomonal cephalosporin like tazocine, cefepime. There are several meta-analyses and reviews proves that the combination therapy is not superior to monotherapy in cases of febrile neutropenia. Okay, so we can start always by cefepime alone or tazocine alone. No need to add gentamicin. Dr. Mohammed Amin is there. He doesn't believe in this. Okay, this is something for you. Monotherapy may not be appropriate for centers with high rate of resistance or for patients who present with hemodynamic instability. So we can add gentamicin if the patient is unstable at the beginning, or your antibiogram in the hospital showing high rate of resistant gram negatives. We can always entertain the indication of vancomycin. Of course, these are known indications worldwide. If the patient have evidence of catheter infection, mucositis, if the patient have pneumonia, hypotensive, if the culture is already positive with gram-positive organism, or if the patient is already colonized with gram-positive organism like strep pneumo resistant, MRSA, or VRE. So the key point here is you have to assess your patient on a daily basis for febrile neutropenia and assess your management. You might, for example, de-escalate the therapy if you have a positive culture that can be de-escalated. Then more than 4 days, if the patient is still having febrile neutropenia, you can entertain the use of antifungal. And the antifungal is wide. It's according to your policy. You can go with echinocandin, voriconazole, or even liposomal amphobi. Here in this stage, more than 4 days, you have to consider CT scan, CT chest, sinuses, and lungs. The trick is always in discontinuation of therapy. We can always start the biggest gun, but when to de-escalate, and this is an area of debate also. So if the ANC is still is improving more than 500, and the patient is asymptomatic and afebrile for 48 hours, you can always stop antibiotic. So no neutropenia and no fever for 48 hours, discontinue antibiotic. But if the ANC is still low and the patient has no complication and he's afebrile for 5 to 7 days, you can stop antibiotic as well, although he is neutropenic still. This might not be applicable in cases of high risk or intensive chemotherapy or high risk acute leukemia. Patient with persistent fever despite neutrophil recovery, so neutrophil has increased but he has still fever, you have always to consult your ID and microbiology. They might consider antifungal for you or stop antibiotics. For every patient with febrile neutropenia, we have to consult our infection control personnel and consider the environmental factor. Hand hygiene is a must for every healthcare personnel coming, even the visitors, even the patient himself. We have to consider neutropenic diet, and our dietary colleagues, they know what do we mean by neutropenic diet, which is no raw vegetables, no raw fruits, well-cooked meat, and etc. The room ventilation should be in a positive pressure. Patient with transplant should be in at least 12 air exchange per hour. Oral hygiene is important, so toothbrush at least 2 times a day, flossing at least once a day. Daily showers or bath, plants and pets should be prohibited, unfortunately. So lessons to be learned from my presentation, and again, I'm biased because I'm ID. I want you to get those lessons. So low-risk febrile neutropenia can be treated by outpatient therapy. I hope that we can adopt this. Monotherapy is as effective as combination if you don't have high risk or high incidence of multi-drug resistant in your institute. Always keep ID on board for de-escalation, discontinuation, if the patient is recovering from his neutropenia. Thank you very much.
So I ask the presenter to join us here just for QA session. Dr. Wabari. Yeah. Dr. Yazan, is he around?
I don't know if Dr. Naji is online or.
So any questions from the audience? Yes.
أنا بجلس إذا في سؤال.
Assalamu alaikum wa rahmatullah. Thank you very much for the speakers. Yes, thank you very much for the speakers. My name is Yasser Wali from Oman, Pediatric Hematology Oncology. My question is to Dr. Zainab for the febrile neutropenia. Actually, there is a comment, I can't agree more of starting monotherapy, and actually we start monotherapy for all our patients in Sultan Qaboos University Hospital. And after 48 hours, maybe I want to have comment on that. Even if the child is continued to be neutropenic, but if he's afebrile and the blood culture is negative, we stop the antibiotic therapy. So I want your comment on that.
And I would like to thank you for this comment. I didn't expect an oncologist who would agree with us. Thank you. "48 hours if recovery of neutropenia." This 5 to 7 days. 5 to 7 days if you have neutropenia. Yes.
Okay, I have. Excuse me.
Yeah.
Okay, I have a question for Dr. Naji and Dr. Ahmed. You have a patient, triple negative, Russian. She's 42-year-old. PDL-1 20%. She received induction neoadjuvant chemo and immunotherapy as standard. And after completion of her treatment, she did not attain complete pathological response. Lymph node negative, used to be positive by sentinel node. She still have residual primary site. So now the question is, what to do next? By the way, BRCA somatic is positive. BRCA, yeah, somatic. So what do you do next? A, even after radiation therapy, A, to go for continued immunotherapy, pembrolizumab, to complete 1 year, and cabestabine for adjuvant setting after completion of radiation therapy, or no immunotherapy, just cabestabine, or go for PARP inhibitor. She's 42. Well, it's, you know, it's residual. It's not much. There's too much necrosis, but there's no microscopic. Microscopic. T1, yes. But N0.